Welcome, everybody. My name's Dr. Catherine Chan, and tonight we're going to talk about conquering Palladia, so key insights for pets with cancer. So thanks for joining us either live or on-demand access later. So my name's Kat Chan, and I'm the founder and director of The Pet Oncologist, and we're an online veterinary oncology consultancy service, so specialist board-certified veterinary oncologist that provides consultation reports, advice, support, and education for you. Alongside with Dr. Amy Lane, we provide advice support Monday through to Friday from 9 a.m. to 3 p.m. Australian Eastern Standard Time. And I can see some names pop up, some familiar names. In addition to our online services, we also offer a mobile in-clinic service for chemotherapy and ultrasound in Brisbane. And on top of this, we also provide free CE webinars for you, thanks to sponsors such as Zoetis. So once again, this webinar is proudly sponsored by Zoetis. So Zoetis supports vets and pets worldwide. They've been around for a while and they're dedicated to advancing veterinary care through medicines, vaccine, diagnostics, and technologies. And I'm incredibly grateful for their sponsorship, who make our free CE veterinary oncology webinars possible. So thanks to Zoetis for that. And so with that, I will hand over you to Dr. Richard Elstrange, an Australian veterinary operations manager and companion animal and equine. And thank you so much, Richard. Let's take a moment to hear from our sponsors.
Thanks, Kat. We're very proud to sponsor this webinar. The topic, being Palladia, which is one of my favourite Zoetis drugs. So I thought I'd just spend a few minutes just giving you a bit of an idea of what Zoetis's ethos is and how we try and support the veterinary and the wider pet owning community. So you can change to the next slide, please, Kat.
Mm-hmm.
So Zoetis is a big company. We're the largest, actually, animal health company in the world. And I'm not going to walk through all those stats there on screen, all those large numbers, but the one I really want to draw your attention to is the one pretty much right in the middle. It says 1,600. That's actually the number of people employed by Zoetis to do our research and development. So their sole job is to discover and develop the amazing new drugs such as Palladia and others that help you guys in clinic every day. And we're particularly proud of that. Next slide, please, Kat. And that sort of leads us to our purpose. All companies like to have a purpose, and ours is pretty broad. It's to nurture the world, no small thing, and humankind by advancing care for animals. So if we figure if we focus on animals, then everything else takes care of itself. Next slide, please, Kat. And as well as research and development, we like to do charitable work as well. You can see some pretty big names here on screen that we support. Beyond Blue at the top there is one of the ones we're most proud of. Seeing Eye Dogs, we're a major sponsor of those, and the AVA, they're right in the middle. And I'll talk a bit more about how we support the AVA as we go. So next slide, please, Kat. And to go back to that R&D program, that we give those 1,600 people some money to play with every year. You can see the number there on the left of the screen. Last year, it was $950 million Australian, which is no small sum. And I'd imagine this year, it's well over $1 billion Australian. So, and we can only do that with your help. So it's, if you purchase products from us, then you're helping us to do this great work. And we can't do it, obviously, without your support. So thank you all very much. Next slide, please, Kat. And you can see here some of the amazing products that have come to market through your support and that R&D over the years. Right at the bottom there, Convenia, which has been around a long time now. And you can see Palladia up there above Convenia, appeared in the market in 2012. So it's hard to believe we've had Palladia for 14 years or so now. And then as we go up screen, Apoquel, Cytopoint, Silencia, Baranza, and then right at the top right there, we're about to revolutionize the in-clinic laboratory market through the VetScan OptiCell, which is our amazing new hematology technology. So you're going to hear a lot about that in the coming years. Next slide, please, Kat. Another thing we like to support is this organisation called HABRI, the Human Animal Bond Research Institute, and this is an organisation that explores the links between human health and pet ownership. And you can see some of the areas there on screen that research has been done in. And if we go to the next slide, Kat, we can see some stats here. If you ask pet owners directly, does having a pet impact positively on their health, whether it be social, physical, or mental? 89 say yes, but if you ask them indirectly, sort of in a round and about way, then that number goes up to 98. So almost every pet owner derives a benefit on their own health from owning a pet. And what that means is that you guys, as practitioners, are human health practitioners as well as veterinary practitioners. So sorry to add to your burdens, but you are. Next slide, please, Kat. And that leads us to our veterinary mental health support, given that you carry that burden. The Zoetis Foundation, which is a global organisation, has been funding the pilot program for the Thrive mental health workshops run by the AVA here in Australia. So we're very, very proud to support that as well. Next slide, please, Kat. And at a more ground level perspective, you can see some attractive faces here on screen, and I'm very proud to be one of a team of 6 veterinarians whose job it is to support you guys from a technical perspective. So if any of you need help in any way about a Zoetis product or disease that we are involved in, then you can ring that 1-800 number there on screen. And if the product support team can't answer your question immediately, then they are very happy to pass you on to one of those very good-looking people that you see there on screen. So we've got some great expertise there. And finally, if you're a CE junkie, then please visit our Zoetis Academy. And there are dozens, and I mean dozens, of webinars there to watch and rewatch if you want on lots and lots of topics, including webinars on Palladia even. So please, visit that at your leisure. And I think that is me done, Kat, if I'm correct. That might be the very last slide. So thank you all for that brief overview of what Zoetis gets up to, and we're very proud to be involved in the animal health world. So on with the show, Kat.
Great. Thank you so much, Richard. Before we start, Richard, if you can admit people, that'll be great. And
Yes, I'll do that.
Thank you so much. And so before we start, I just wanted to say the pet oncologist acknowledges the tradition custodians of the land where our Australian business is located. We pay our respects to the elders past, present and emerging, and we recognise the enduring connection of all the nation's peoples to the country, land and sea. I have the following disclosures to make. So we do have sponsorship for our webinars and our chemo workshops, but these sponsorships are unrelated to this presentation and do not affect the content or information presented. So we actually chose to do Palladia, and Zoetis was very proud to sponsor our talk. So I'm going to go through the good and the bad from my point of view. I do love Palladia, but what I say in this talk is not endorsed or restricted by Zoetis or Richard in any way. So before we start, I'm going to release a poll. So bear with me while I do this. So I'm going to release a poll question, the first one. So the first poll question I have is, how many of you are currently using Palladia in your practice? So hopefully you'll see that question come up. I'd like to know, and I'll give everyone just a little moment. Okay, so I'll wait until most of us has clicked something. Okay, so I'm just going to end the poll now. So sorry to those who can't finish. And I'm going to share the results. So hopefully you can see the results here, but only 10% are giving Palladia regularly. About 38% are doing it occasionally. About half of you are not quite there yet, but are interested. So that's really, really interesting. So hopefully you'll be more interested after this presentation. Okay, so on with our presentation. So what we're going to go through is contents, pretty much frequently asked questions. So I'm going to go through what is Palladia, how does it work, and how it differs from metronomic and conventional chemotherapy, and what cancers can we use it for and how effective it is in both dogs and cats. And a lot of the data is for dogs, so you'll notice this talk is predominantly dogs, but we'll go through cats too. And we'll also go through dosages. So what dose do we give and how frequent? And what side effects to look out for. But not just that, but we'll also be looking at monitoring and management of side effects, because I think it's really important for you out there to be able to give Palladia. And for me, I'm really going to focus on the practical applications for GP vets. So I do actually expect you to hopefully be able to use Palladia in clinical practice. We're going to go through tips and tricks as well and some Q&A at the end. Now, this topic is a really, really big one. So I'm going to stick to 50 minutes from now, or 45 minutes so that we can finish in an hour. And know that the Q&A, there were so many questions submitted, I won't be able to go through it all, but we can actually nut it out at the end for those who are interested. Those who want to wait, I'm more than happy to, but if you're done, you can just leave and watch it later. So what is Palladia? So Palladia, also known as tesseramin phosphate, is an anti-cancer drug. That's the first USA FDA-approved drug for treatment of canine mast cell tumors. It is not chemotherapy. So we'll talk about the difference. It is an anti-cancer drug and it's a molecular targeted drug. And when people ask me that, they ask me, what does it mean? So to simply start, I tell them it's an oral tyrosine kinase inhibitor. So it's given orally and it inhibits tyrosine kinases. And to keep this simple, tyrosine kinases are cell signaling proteins that are overstimulated in cancer. So you can turn it off, then you can treat the cancer. And so you get decreased growth, proliferation, and survival. So another way of seeing it is knowing that it does multiple tyrosine kinase inhibition and specifically KIT. So KIT is present on mast cell tumors, gastrointestinal stromal tumors, and also vascular endothelial growth factor and all these other ones. So know that Palladia actually works on many different tyrosine kinases and particularly KIT. That's really important to know because that's present in mast cells. So, oops, sorry about that. And also, it will make sense soon. So when you go through this, it's like, oh gosh, this is quite intense. But it's actually really important to know how they work to understand side effects as well. So anti-angiogenesis, for those who attended the metronomic talk, basically anti-angiogenesis is preventing new blood vessel growth. So cancers can't grow more than a few millimeters if there's no oxygen and nutrients. No blood vessel supply. You get no oxygen, no nutrients. And then another thing is immunomodulatory. So simply speaking, it just decreases the bad T cells, puts up the good T cells, and by doing that and many other ways, it can modulate the immune system to recognize there's cancer there and treat it. So know that Palladia is actually quite great. Even though it's not chemotherapy, which directly results in cell killing, it does both. And I'll go through how it does a quick and a slow death. But know that it has multiple mechanisms. So multiple tyrosine kinase inhibition, anti-angiogenesis and immunomodulatory. And that's really important when it comes to how it works. So this is just a diagrammatic representation of it. So this is an example of a tyrosine kinase that's, in this case, it's a mast cell. So ignore the words at the top at the moment. So just know that this is a normal mast cell and you have a receptor on the top. When you have a ligand, which is what you can see there as stem cell factor or SCF, when it's off, you don't have any action because it's not connected. However, when you have them touch, so this is a normal mast cell, when they have a connection, you actually get cell signaling. So you get growth, proliferation, differentiation, and survival. Now, when you have a mutation in a mast cell tumor, it actually occurs in the cytoplasm. What happens is you don't need to attach. So you can see that ligand is not attaching. And then it just goes crazy and it just keeps producing these mast cells. And that's how mast cell tumors develop. So the way Palladia can work is by inhibiting KIT, it does it in the cytoplasmic pocket, it actually stops this growth. So that's an example of how it works by one mechanism of tyrosine kinase inhibition. But knowing that, so how does it differ from chemo? So knowing that those got those three different mechanisms, why is this relevant? It's important to know that it's not chemotherapy. It is anti-cancer, but it's not chemotherapy. Now, when we talk about chemotherapy, think of it as an injection or an oral administration. So something that you give systemically to the whole body, and it targets rapidly dividing cells. So you basically give it at the maximum tolerated dose to kill cancer cells. So that's the aim of chemotherapy. You want to give it the highest dose to kill cancer. And by doing that, you aim for rapidly dividing cancer cells. But as we know, you can get side effects as a consequence. So just know that chemotherapy is usually a quick death. So it's usually really, really rapid. Now, metronomic chemotherapy, remember how I mentioned Palladia does this too, anti-angiogenesis, so preventing blood vessel growth and immunomodulatory. This is important to know the difference because usually metronomic chemotherapy is a slow death. Because if you think about it, if you starve of any oxygen and nutrients and you use the immune system, it's going to take a while to die. But Palladia can be a quick or a slow death. We see this clinically when we give Palladia. It can work really quickly. It can be a slow death. So why is that? Well, if you inhibit a tyrosine kinase, if that's the main pathway of the cancer to grow, so for example, a KIT mutation, you get a quick cell death. Hence why when you give Palladia to some mast cell tumors, they die quickly. And then sometimes you're like, oh, it takes a long time to work. And that's probably because of the anti-angiogenesis, so blood vessel and immune modulator growth. So know that Palladia is unique in that when you use it, you can have a quick death and a slow death. So when we give Palladia, I thought I'd start with kind of a broad overview before I go through specific cancers that you can use it for. Many, many, many cancers. So Palladia is a great drug for many cancers. Not all of them though, but many cancers. So things that you can consider it for are unfavorable prognostic factors. So if you've got widespread metastasis, so you take x-rays and you see this, obviously you need a histological or cytological diagnosis of some kind first. I don't give it without having that. But this is an example of when you'd go, Palladia may be good for this, particularly if it's carcinomas. Another thing is if it's unresectable. So if you can't remove it, so owners don't want to go to surgery or it's too big to go to surgery or radiation's not an option, having gross or macroscopic cancer is really good. And I actually focus on this for Palladia. Palladia has actually been shown, just like in humans, to be better for macroscopic gross disease. You can use it in the adjuvant setting, kind of question it in some cancers, but it's mainly used when you can see the tumor. You use it when there's surgeries or other therapies are not possible. So as I mentioned, owners can't do surgery or radiation's not possible, or they failed standard of care. So you tried things already. You tried surgery, you tried radiation, you tried chemo and it failed. So Palladia can be considered then. Or the owner wants to try some oral anti-cancer drug. That's not always the best option, but that's an example. And when you do it, particularly if you've got gross macroscopic cancer, it's a trial and see. So you try it and see if it works. If it doesn't keep the tumor stable or it starts to grow, so if you notice it start to grow, it is not working. You need to stop. And even though some people say to me, oh, but it takes a little bit longer sometimes for it to work. If it is not working, you need to stop. So let's start with mast cell tumors. So this is the reason why Palladia was created. So first, when the studies came out, they used it on mast cell tumors. So I won't go through the details, but I will go through how it's used for mast cell tumors. So I actually use it when there's gross disease. Can't remove it, it's metastatic, or it's recurrent like this. So this is recurrent and seeding along the line. You can't do surgery for that. And so I would do it in that situation, or when I have a c-KIT mutation positive tumor, but not necessarily all c-KIT mutation positive mast cell tumors will be indicated for Palladia. Just know that these are some of the reasons. I also use it again, similar pattern, when we have no response to traditional chemotherapy or for high grade or grade 3 mast cell tumors. So these are where you can consider Palladia and high risk cases. For me, I use Palladia mainly for when there's gross disease and there's metastatic disease. And I do feel there's many other options. I don't just jump to Palladia. I don't use it in the adjuvant setting. So for example, if I remove the tumor, I say a high-grade mast cell tumor, I don't actually use Palladia. There's more data to show that chemotherapy is quite effective. And the problem with Palladia is how long do you use it for? No one knows. We use it for 6 months, 12 months. Once you start, you kind of don't stop. And it's a hard one because when you don't have tumor to measure, sometimes you go, oh, owners don't have money, I'll stop in 6 months. And then the tumor comes back with a vengeance. So the thing with Palladia is if you can't see it, it's actually really hard to target. And it's actually been shown in many studies, and I'll go through it in this presentation, that Palladia works better in the gross disease setting. And that's the same with people. They live longer when you can actually see the tumor and you use it. Doesn't mean you can't use it in the adjuvant setting. That's not how I use it. So mainly I use it for macroscopic metastatic mast cell tumors. And one thing I wanted to mention, if you don't know already, if you haven't heard from my previous presentations, is chemotherapy and Palladia does not prevent the development of new mast cell tumors. And I won't go through that in detail here, but you can email me if you're interested in finding out why. So again, for macroscopic gross mast cell tumors, so if you don't treat, the average survival time is variable, but usually less than 3 months. And this is dogs. But when you use Palladia, the response rates are roughly 40 to 70%, so quite high in my world. And most dogs will clinically feel better. And the average survival time is variable, but it's 3 to 12 months. And in some cases, you can get complete remission and they die of something else. So this is an example of a 17-and-a-half-year-old female spayed Jack Russell with an oral mast cell tumor. You can see that it's quite necrotic, and this is an older dog. That would be quite aggressive to do surgery. And this dog actually had PRED beforehand, so we couldn't even decide to reduce it. So we gave Palladia, and 1 week later, the mass was gone, or the mass was reduced in size. You can still see it here, but this one, you can't see it anymore. So the dog did really, really well. When you have a gross or macroscopic mast cell tumor, and for those who have already attended the talk, I apologize for repeating it. I think it's really important to give them prednisolone as an anti-cancer effect with Palladia, but Palladia and prednisolone are not given on the same days. This is really important because they both cause GI upset and you don't want gastrointestinal ulceration or perforation. So avoid giving them on the same day. And people ask me, what do I mean? So if Palladia is giving every second day, then Pred will be given on the off Palladia days. And so you also give it with claritine, so an antihistamine is really important, and some Losec. And antihistamines are important to reduce the histamine relief, and the omeprazole is really important to prevent the histamine irritation to the gut lining. So it helps preventing ulcers. And for cats, ondansetron is really good because cats' mast cells actually release, mast cell tumors release serotonin. So this is really good, particularly if they're feeling unwell. And I just wanted to mention with new data coming out that esomeprazole is a convenient way of doing it once a day in dogs only. In cats, you still have to do it twice a day, but this is really, really good for owners that are like, this is way too many medications. So you could just put it all together in one big gel capsule or something and give it together. So c-KIT mutation, I just briefly mentioned, occurs in roughly 30 to 40% of mast cell tumors, typically the grade 2 or 3, so the higher grades. And you could get this test done in the US by just a paraffin-embedded histopathology sample. And I just wanted to mention that when you have exon 11, there's many of them, that's associated with a more biologically aggressive mast cell tumor. So those cases can be really good for Palladia. And the average survival time, unfortunately, when you've got KIT mutation, is pretty bad. Even with Palladia or chemotherapy, you can throw everything at it. Unfortunately, when they've got this mutation, the average survival is about 3 months. And in the past, I used to be like, oh, there's a study that showed that if you use Palladia, 70% will respond. And if you don't, and I'm sorry, if you have a c-KIT mutation, 70% will respond to Palladia. Whereas if you don't have the mutation, only 40% respond. And that's because they don't work. Palladia works by other mechanisms. So based on that old data, before new data came out, I used to be like, oh, well, if they've obviously got this mutation, I'm going to test for it, then I'll use Palladia because Palladia is going to work in 70%. And it makes sense. And you want to know because it's associated with the worst biological behavior. However, more recent data has come out to show that it does not matter. They did a study with vinblastine and Palladia, and they showed that the c-KIT mutation status did not matter. So based on that study that came out 7 years ago, I actually do not care about the c-KIT mutation anymore. I do if it's going to change your owner's decision to treat. So as a part of my prognostic screening, but I would use Palladia anyway, even if it's c-KIT negative. And just because it's positive, I still feel that yes, they probably can respond better, but they can respond better or they can respond more even if it's negative. So just keep that in mind that I use it for prognosis now. It's really good for systemic mast cell tumor metastasis. So that definition of that is when you have 2 lymph nodes affected. Yes, that's correct. When you've got 2 lymph nodes, it's systemic mast cell tumor metastasis, spleen, liver, or gut involvement. And without treatment, they can be really sick and average survivals of 1 to 2 months. But with Palladia or chemotherapy, the response rates are roughly 40 to 70% for an average of 3 to 12 months. And again, always give supportive care with these gross macroscopic mast cell tumors. So as we know, we've spoken about Palladia for around 10 minutes now. We know that mast cell tumors, there's a lot of data for. But luckily, the oncologists who study Palladia tried it on solid tumors too. So we now actually know we can use it for many other tumors. So one of the big ones is apical gland anal sac adenocarcinoma, also known as AGASACA when you shorten it. So there's actually a few studies out there. So without treatment, if you've got stage 4, meaning you've got metastasis, say to the lungs, average survival times are roughly 2 months. But we all know it's quite variable because if it's slow growing, it can take longer than that. But know when you give Palladia, roughly 1 in 5 or 1 in 4, so 20 to 25% will shrink. And in addition to that, half or more of them will actually stay the same. And so for me, success for Palladia would be a dog that's not clinical from it and stable disease. Because if you can stop that tumor from growing and that dog lives with a yucky big mass, as long as it's got a good quality of life, it's not impacting it, I think stable disease is considered success for Palladia. Now, keep this in mind that it's not the same as chemotherapy. In chemotherapy, you really want to shrink it. So just really keep that in mind. So know with a lot of these, we'll talk about clinical benefit, which is stable disease or better. So for this anal sac tumors, there's 2 studies that showed that stable disease or response to Palladia occurs in many of these cases. And the average survival time is actually 1 to 1.5 years. So that's great when they've got metastatic disease. So in these studies, 87% had pulmonary metastasis. And so they lived about an average of a year. And so for me, I thought that's really, really good. And clinically, we see this when we have widespread pulmonary metastasis, just like this, or widespread nodal metastasis. These cases actually do great on Palladia. The one thing I do mention is we don't have data on, but it's just an anecdote. If you've got liver metastasis for anal sac tumors, it's guarded. Unfortunately, no matter what we do, even with Palladia, it's not a year. It's usually 3 to 6 months. They're not as great. And that's got to do with the liver not being able to detoxify things really well. Again, other things we can treat it for. So nasal carcinomas in dogs. So without treatment, it's roughly 2 to 3 months, but we know it can be a little bit longer or a little bit less. But in one study, Tara Ealing, who I know personally, she's lovely. She is a radiation oncologist, and she treated 13 dogs with Palladia and showed that around half of them actually benefit. They stay the same and or shrunk. And they can actually go into complete remission too. And the average survival is roughly just under 10 months. And that in my world's quite good, considering that no treatment's only 2 to 3 months. And I do clinically feel that half or more will benefit from therapy. And when she threw radiation in it, so she did 50 dogs, the response rate was phenomenal, 80%. There was actually some complete remissions there, and they survived 1.5 years, so a little bit longer than the standard of care. So I felt like Palladia can play a really good role with radiation or alone with nasal carcinomas. And just for some context, if you do some chemotherapy, carboplatin or doxorubicin instead, 2 studies show that the average is about 7 to 7.5 months. So for me, around 10 months with Palladia is quite good. And I actually go to this as my first line now for medical options for nasal carcinoma. And then frontal sinus carcinoma, which is similar to nasal, not the same. So with this one, there's a study on 41 dogs just to show you the average survival is around 6 months, which I think is better than no treatment. And a lot of these, 10 of these dogs had meloxicam. But I thought I'd just mention to you that these guys can do well too, and I've seen them clinically. Another tumor, so thyroid carcinoma. So there's actually a lot of tumors you can treat this for. So without any treatment, the median survival time is 3 to 4 months. Again, this is variable because we've seen thyroid carcinomas that stay there for a long time. So know that when I give you these averages, this is the average, like the 50% mark. Of course, we see cases that do longer or shorter. So I just thought I'd let you know that when you give owners averages, always talk about this is the 50% mark, not necessarily what's going to happen in their dog. And it's important that you mention that. So it's used in people for advanced thyroid carcinoma. So they use tyrosine kinase inhibitors. And in a study of 42 dogs with more than 60% with pulmonary metastasis, the response rate was quite phenomenal. It's actually higher than anal sac tumors. So it's a quarter to half actually shrunk. And another 40 to 53% had stable disease. So most of these cases will do well, and phenomenally, an average of 1.5 to 3 years. And clinically, I say I'd see about a year in many of these cases. I don't think I see a lot of 3 years, but I have occasionally. But this is the data for this study. And I do feel that they do really good on Palladia. And then we have nasal, or we have head and neck tumors in general. So I'm talking squamous cell carcinomas. So these, you can have frontal sinus tonsillar, oral squamous cell carcinomas, and there's cases out there that show responses. So I'm not going to go through in depth, but just know that they can work for these tumors too. And I had a tonsillar squamous cell carcinoma that had metastasis to the lungs, and I was like, this is not great. I only wanted to do Palladia, and it was alive a year later. So no, sometimes it's what I call the potluck. And sometimes even for, I know I say that a lot for cancers, but sometimes it's a trial and see. And if it works and it's potluck, it's one of those rare ones, it's great. When they go in complete remission, they can do really, really well on Palladia. Another tumor is gastrointestinal stromal tumors. So these do excellent with Palladia as well. So they typically are c-KIT positive and recommended in humans. So humans will use similar drugs when they got a mutation in KIT. In a study of 20 dogs with surgery in Palladia, so they actually had surgery to remove, say, the primary, you can't see anything anymore, and they did Palladia in the adjuvant, so microscopic level. The median progression-free interval was 1.3 years. But surprisingly, when 7 dogs who had gross disease, so they had masses like this or pulmonary metastasis, they actually mostly responded or had stable disease. So 71% felt better, the tumor didn't grow or they shrunk, and the median progression-free interval was 2.1 years. So this is an example of where macroscopic gross disease works better for Palladia, and it's actually similar in people. So remember this, that Palladia actually works better in the macroscopic or gross disease for many cancers. And this is one of them. So when I actually have surgery for these cases, I don't put them on Palladia. I just wait and see. And if they're aggressive, I try some chemo, and then I consider Palladia when they've got mets like this, if they get mets like this. Another one is osteosarcoma pulmonary metastasis. So unfortunately, when you've got sarcomas, they don't typically respond well to anything. You can throw chemotherapy at it, Palladia, sometimes they just don't work. Unfortunately, when you've got pulmonary metastasis, it's roughly 2 months with osteosarcoma. This is appendicular osteosarcoma. So these studies had pulmonary metastasis. They didn't do bone metastasis or anything in these studies. But the first study that came out many years ago showed half of them responded for 6 months. And I was like, oh, that's great. I'm going to use Palladia for all pulmonary metastasis for osteosarcoma. And then we saw that it actually wasn't like that. And that showed in 2 studies afterwards that showed only 10 to 15% actually had a clinical benefit, meaning they had stable disease or shrunk for an average survival of 3 months. But the good news is, because that made me sad, because I was like, oh, I was really hoping Palladia would be the drug for pulmonary metastasis for osteosarcoma. However, it can be. So with losartan, so losartan is actually an angiotensin receptor blocker used to treat hypertension in people. And this smart guy, Dan Regan, who I actually met in person, he's one of those gigantic geniuses who just is a walking genius. He decided to do some studies on mice and then eventually correlate it to dogs and showed that losartan can actually inhibit monocyte migration in metastasis. So if you go to the metastasis level in osteosarcoma, it inhibits the monocyte migration. By doing that, you can actually prevent metastasis from developing. I thought that was brilliant. And he actually did it clinically and showed that half of these dogs actually had a clinical benefit and they lived just under 5 months. So my gold standard now is actually losartan and Palladia for osteosarcoma. And I think they tolerate it really well. The losartan dose actually has to be quite high, so 10 mg per kg twice a day. And you use it with the current Palladia protocol. You can get hypertension, but with close monitoring, it's very well tolerated. And I call Palladia the hit and miss with this one because I actually had a case that I actually published in ABP. So this dog was Ella, who was a 10-year-old Jack Russell, had metastatic osteosarcoma 10 and a half months post-amputation. We did carboplatin, and I was like, oh, that sucks. You can see Mets there. You can see those two arrows that show it clearly. Put the dog on Palladia, kept taking x-rays. They didn't shrink for a long time, but at the 9.5 month mark, I actually saw partial remission. These are not high digital x-rays, but can actually still see some little nodules there. And then we just kept going. And sadly, the patient died 5 years later on Palladia with this last x-ray that we got here. I can see that tiny nodule I wanted to show you and died of renal failure. So keep that in mind. And I'll just go back here to say that chemotherapy for osteosarcoma is poor. I know it's an old study in 1993, but they used mitoxantrone, doxorubicin, carbo and showed gross osteosarcoma had a 2.2% response rate. I thought that was horrible. Only like 2 or 3 responded in that study. But just know that we still don't have a lot of great options, but Palladia is what I choose. And then more things that you can use it for. So a lot of this talk is what cancers I can use it for. And then I'll wrap up towards the end so we can talk about how to monitor. So insulinoma is a really good one. So you can actually use it for gross insulinoma where owners don't want to do surgery, but particularly stage 3, I'm talking the ones where it's got liver metastasis or lung metastasis. Because as you know, with insulinoma, which if you don't know what it is, it's a pancreatic tumor that causes hypoglycemia. And it's made from, it's an islet beta cell tumor. And basically, these tumors can make dogs feel really, really hypoglycemic and sick. And when you've got stage 3 metastatic disease, despite supportive care, it's roughly 6 months. But in people, they use a similar drug called sunitinib or Sutent, and they showed that it had improved survival over placebo. And so there's studies to show that if you do a partial pancreatectomy, so you just remove this part of the tumor, not even the whole thing, you just remove some of the insulinoma. And ideally, you want to take the others out, but you don't have to take the liver mets out or the pulmonary mets. And you do Palladia, you can actually survive a long time, and dogs and cats can live more than a year. And in recent studies, it's kind of hard to know what stage 3 does, but a mixed bag of stage 1 all the way to 3. So they're talking about, stage 1s where they haven't spread yet to lymph node, stage 2 and 3 to, hepatic or pulmonary mets. They actually show that the average was about, in 4 studies, about 1.2 years with Palladia, which I thought was pretty good. Some of them did have partial pancreatectomy, which makes sense. But it goes to show, even if you have mets in these cases, if you debulk it, which I normally don't recommend, if you debulk these tumors and actually follow up with Palladia, even though they've still got disease in the liver, they actually do well. Now, remember how I said liver doesn't do well with Palladia? This is the one exception. Remember how I said if you've got Agasacas, the anal sac tumors with hepatic metastasis, they don't respond well. For some reason, the insulinomas do really well. And it may just be that it helps lower the glucose because I still, in these cases, see the nodules. I still see the hepatic nodules, but they clinically respond better. I'm not talking a huge reduction in size, shrinkage, but this is an example of metastatic liver mets from Palladia can work well, or insulinoma can work well. But the problem is you've got to be careful with prednisolone in these cases. We use it as part of the insulinoma treatment, but they can develop diabetes. So my thoughts with this is just use a low dose as possible, and please make sure that you monitor for diabetes because it can actually kill them. It actually isn't the cancer itself. And I've seen that a few times. And we've actually had reports of it just Palladia alone. So Palladia alone can cause such a great response that they actually end up getting diabetic. So very interesting. Again, this is the exception with the liver, so I put that there. Another thing is chemodectomas. So we typically see heart-based tumors, chemodectomas, aortic body tumors, you can call it what you want. But basically, these mainly occur in brachycephalic breeds because of the chronic hypoxia, we think. It stimulates the chemoreceptors or something, and you get this heart-based tumor. So you can see a CT of it beautifully there. Now, without treatment, it's 1 to 3 months, especially if you've got cardiac tamenard. That's going to be hours to days or weeks. And so with Palladia, it's actually the standard of care, these kind of drugs for metastatic advanced neuroendocrine tumors, including chemodectomas. And so there's a study that showed that 28 dogs treated with Palladia actually had a response rate. So it actually shrunk 1 in 10 to 30% of cases. 90% improved. So even with the cardiac tamponade, you do have to get rid of the cardiac tamponade for them to clinically feel well straight away. But they actually clinically respond to Palladia. And I've seen this clinically where I've actually seen massive reduction, not complete remission, but massive reduction with Palladia. And the average survival is roughly 2 years if they have no mets and 1.5 with metastasis. So for me, that's quite good because traditionally we just do a pericardectomy, similar survival outcomes of 2 years. But know that you can't compare them. None of these studies go, we're going to compare Palladia to pericardectomy. And know that stereotactic's similar too. But just know that it's actually quite a good, useful, palliative treatment that you can use for these tumors, as long as you control the cardiac tamponade. So another thing is pancreatic carcinoma. So this sucks. Everyone who knows about pancreatic carcinomas in humans, in veterinary medicine, any species, it is a terrible cancer. Median survival time in the literature is 1 day to 1 month, even with treatment. It's horrendous. But in a small study of 6 dogs, 75% actually felt better on Palladia for an average of 3 months. Now, when I've used it, and you can see one survived 506, when I've used it, I think it's really hit and miss. I find that some do really well, but some just feel sicker on Palladia. So I just keep that in mind. Another study showed this one case where a dog had a partial pancreatectomy and adjuvant Palladia. Remember how I said I don't use it in the adjuvant setting? Well, in this setting, it actually did okay for about 1 year. That's actually pretty good for this terrible terminal cancer. It's highly metastatic. So again, Palladia can be used like that. And then renal carcinomas, you probably noticed the trend, carcinomas, neuroendocrine tumors, but they're actually quite good. So in people, they use it for renal carcinomas and the response rate to chemo is poor, 5 to 15%. And with tyrosine kinase inhibitors, it's not much better, 25 to 35, but that's better than chemo. And there's many, they use many in people, but know that they're mainly KIT positive. And because of that, they can respond well to Palladia. I don't know, we don't have any studies. Someone who can do a study on this will be great. But renal carcinomas in one study showed 12 out of 13 were KIT positive. And it's a chemistry stain, not a mutation. And that was great because it made me positive about using it. And I've used this in a couple of metastatic renal carcinoma cases. And anecdotally, I don't have a response rate for you, but I think some of them do okay on it, particularly German Shepherds. And then others. So I'm not going to go through all of them because I know it will just be too much and overwhelming. But no, you can use it for pheochromocytomas. You can use it for hepatobiliary carcinomas and carcinoids in dogs and cats. Neuroendocrine tumors, that's pretty much the gold standard for humans with metastatic. So if you've got this terrible neuroendocrine tumor carcinoma that's metastatic, particularly in dogs, try Palladia because it can actually do well. And then you've got other carcinomas. So hepatocellular carcinoma, they can actually do quite well on Palladia. I really do think it's hit and miss because it is the liver that regenerates well, but there are a couple of cases out there I've treated that have done well and it's been reported. Just know that unfortunately hepatocellular carcinomas have a lot of liver damage. In that study, if you've got an ALT of up to 590, then they use Palladia. For me, I would feel nervous going higher than that. So I actually don't go higher when it's roughly 600 for ALT. I just feel Palladia is actually excreted by the hepatobiliary route. So I worry if you've got liver damage, if Palladia is going to actually make it worse. So just keep that in mind when you treat liver tumors. Bladder tumor, I don't think there's strong data for, but there's data to show it can be helpful. And inflammatory mammary, there's actually 3 studies. So for those who don't know about inflammatory mammary, they're mammary carcinomas that ooze and look disgusting. And those dogs are so painful, they're euthanized within days to weeks. The average survival with Palladia was roughly 3 months. And look, I've used it a few times. I haven't had great responses as what they suggest, but look, it's better than nothing. And particularly for a terminal illness, it can help with inflammatory mammaries. And then others. So I'm just not going to go through it, but know that it can be used for others. So that's dogs. And there's lots of others out there. I kind of went down a rabbit hole and did too much and was like, you know what, I'll just stop there. But Palladia can also be used for cats. So we don't actually have a lot of data in cats, but know that oral squamous cell carcinomas is one that you can consider it for. There's 3 papers to show that it can be helpful. As you know, oral squamous cell carcinomas are terrible in cats. Surgery, radiation, whatever you do, it's not great. Without any treatment, they're pretty uncomfortable. They involve a lot of bone and they usually die within a month. In this study, they actually did oral squamous cell carcinomas in 46 cats and 57% felt better, had stable disease or actually shrinkage. And the average survival was 4 months. So it's not long, but it's better than nothing. And I just wanted to say that we still need something better for this cancer because the 1-year survival rate is 6.5%. Same with radiation and surgery. It's just horrendous. And then I actually have a radiation oncologist I won't name, but who's mentioned to me that he will not irradiate them anymore. He thinks they do so poorly. He puts them on Palladia. And then the other thing is gastrointestinal stromal tumor. There's a case of that in a cat. Pancreatic carcinoma. There's a cat who survived with metastasis for 2.2 years on Palladia. And know that and there's one more paper only for cats. It can be used for cats too. So for me, there's not a lot out there. Just know that for the studies, that's pretty much it. And I'm showing it to you. And the feline muscle tumors, you can have a 80% response rate. And look, these numbers are small, but if you had skin location, average is 8 months survival. If you had gut, I thought that was great, 11 months, because as you know, gastrointestinal muscle tumors have a poor prognosis. Also, gastrointestinal is 5 months, but visceral, as in spleen or liver, can have a poor prognosis too. But know that that's it. That's all you got: oral squamous muscle tumors and a couple of carcinomas. But for me, there's not a lot of data out there. And so know that Palladia can be safely used in cats. So for me, I would actually use it for any carcinoma or neuroendocrine tumor, just like in dogs and humans, where conventional treatments are not possible. So radiation surgery or chemotherapy, or they've failed them. I think carcinomas particularly, or metastatic cancer, are great for it. So know that that's when I'll use it in cats. And oh, if you didn't notice that, actually, that cat actually has pulmonary metastasis. So cats are weird. They don't look like nodules. They kind of look more miliary. So how do I give Palladia? So I've done a lot about, what we can use it for, but how do I actually give Palladia? So the dosage frequency. So we'll start with dogs because there's a lot more data in dogs. Not at the label dosage. So the label still says 3.25 mg per kilogram every other day. And look, there's lots of things involved with changing the label, but know that this was an earlier study in 2003. And since then, many studies have shown that the actual dose range is roughly 2.4 to 2.9. I actually rarely go to 2.9. I actually stop it at roughly 2.75. This is in dogs, and we know that you can give it Monday, Wednesday, Friday with food. Always give it with food. So this is what we actually recommend. So if you're using Palladia for the first time, don't go by the bottle. When you give Palladia, it's really important that prednisolone or anti-inflammatories are given on different days. Palladia's biggest side effect, which I'll talk about in the next couple of slides, is gastrointestinal side effects. Knowing that if you give pred and non-steroidal anti-inflammatories, you can actually cause a lot of issues with gut ulceration, diarrhea. It can be a hot mess. So ideally, you should be given on different days. I say ideally because sometimes you cannot, and you have to give low doses on the same day. If you do that, you have to tread with care, because any diarrhea or gut sinus is not good in my world. And I'll go through side effects with monitoring that I think is really important for you. And sorry, that cat's kind of jumping over the words there. So what about cats? There's no studies like dogs. Cats, unfortunately, usually people say, are they similar? I think they're probably similar. I would aim for 2.4 to 2.9 as well. And for me, I would say to you, a lot of cats are different in that they can actually tolerate 3.25 mg per kilogram every second day. And you have to sometimes give 10 milligrams in the smallest cat. You just don't have compounding available. You shouldn't split these tablets because they're not evenly distributed. But know that if you've got a really tiny cat and you have to use 10 milligrams, you probably do every third day. But know that we just don't know in cats what the actual dosage. So some people say to me, well, it's 3.25, obviously, because cats tolerate it better. But I actually think cats can get quite sick on it. They can get quite a lot of anorexia. So I actually do it similar to dogs. There's no actual studies to show, but I do it similar to dogs. This, for the nerdy people, it just shows that the dose range in this pharmacokinetic study was 2.4 to 2.9. And when they did dose reduction, the lowest was 2.2. Because I get asked, well, if I start at 2.4, what do I dose reduce to? 2.2. And to be honest, sometimes you go lower, but you just be careful because the studies show that if you dose more than 2.4, it consistently has efficacy. And it's different to chemotherapy. Remember how I said with chemotherapy, you give the maximum tolerated dose? Not for Palladia. Palladia it just needs to target the receptor, and it can do so at low doses. So for me, the lowest dose you can use that causes a response is best. So I always start around 2.4, 2.5. And the good news is when you start the lower doses, you have less gut side effects. So for me, it's a no-brainer to start at the lower dose. Now, this is just a table of the side effects, and I'll go through each one of them. The main thing I want to spark for your eye is gastrointestinal and rare stuff, because it's important to know that when you're on Palladia and something weird happens, that it might be Palladia. And for me, I draw a picture of a holiday because often people ask me, what do you do when you get side effects? A drug holiday is the number one key. Taking breaks is really, really important from Palladia. People then go, oh, but I'm so worried if I take a break, the cancer will go back. Sometimes that's true, but I think it's really, really important that we actually really, really look after the patients and really minimize the side effects. And I'll go through it because even though it's not chemotherapy, the side effect profile is quite high, 20 to 25%. So I think it's a lot higher than chemotherapy, but it's typically mild. And with education and knowing about it, it's very easy to monitor. So we'll go into depth. Diarrhea. I hate diarrhea with Palladia, regardless of the cause. I don't care if the dog ate McDonald's. I don't care if it ate a garbage. It is serious. You take it seriously. It is on Palladia. Dogs have died of gastrointestinal ulceration and diarrhea from just not treating it, and it can look mild. So for me, early aggressive intervention is extremely important. Any diarrhea, I just go, stop it. It's not worth it. So you actually stop the Palladia I don't care if you just start it. It's really important that you stop it. I don't care if you think it's mild. I don't care if you think it's from something they ate. You have to stop it because it can cause serious side effects. So start anti-diarrhea medications when you stop. So my go-to is metronidazole. It works really, really well. I've tried lots of other ones, but metronidazole is typically the best one for most of the diarrhea from Palladia. And probiotics too. So procoilin, if it's kind of recurrent, I think probiotics is really, really good long-term if they can afford it for any chemotherapy in Palladia patients. It just balances the gut nicely. If metronidazole doesn't work, because there's a couple of cases, you can try loperamide, that's Imodium, give it the hard stuff, or Tylosin sometimes works too. And look, other things too, Peptidil and things, but just know that you just try other things that don't work if it's not effective. A bland diet's important as well. And then I get asked, well, okay, I'll stop the Palladia. Now we're getting better on metronidazole. When do I resume Palladia? Resume Palladia when the diarrhea has completely resolved. This is a hard one for those who have IBD, so when it's kind of resolved for that patient. But adequate gut rest. So don't just go, oh, Palladia's, the diarrhea stopped, it's got a nasty cancer, I'm going to start Palladia today. If you do that, you can actually cause the diarrhea to come back. So really have an adequate gut rest. And when I talk gut rest, think of the gut lining turning around every 3 to 5 days. So wait at least 3 to 5 days of normal feces. I know that's really hard when you start early on, so you can use your judgment, but I typically wait actually like a week or so for them to get better. Be really careful not to introduce too soon because you'll just have diarrhea that can come back and it can be really nasty. And if diarrhea becomes persistent, because you have those cases where you're like, I've done this, just popped it back on, now it's got diarrhea again, what do I do? So if you actually do that, have hope, you can actually give metronidazole. And I do it really strangely, and a lot of oncologists do this too. We just give it once on Monday, Wednesday, Friday. So you give the Palladia, give the metronidazole. And if that doesn't work, you give it once daily. When I start to go to twice daily, I then go, hang on a sec, maybe I shouldn't be doing Palladia at this dosage and I need to dose reduce. But often this does the trick, and adding probiotics. Gastrointestinal ulceration is bad. It is really important that if you suspect it, Melina, you definitely have a drug holiday. You start omeprazole. I even add sucralfate because I know how bad this consequence is. It can kill dogs. It's been reported. So sucralfate given after Palladia, so it does not impede absorption. That's important. Most of us know that, but I just thought I'd mention it after because sometimes it doesn't matter which order, but it does for Palladia. And when do I resume? I start at a low dosage or I extend the intertreatment interval. So sometimes I do every third day, but I start with a lower dosage first if possible. I don't actually routinely give omeprazole and sucralfate. There's studies to show that it actually doesn't help for a lot of drugs, so I don't do that unless I really, really have to. So I try to dose reduce or extend the intertreatment interval where possible. If I've got anorexia or nausea, ondansetron and meropenem is really, really good. But the interesting thing is, and I don't know if it has something to do with the way Palladia works in causing gut stasis, because it actually can slow down the gut movement. Sometimes patients do better on metamide. And I just mentioned that because we all think of metoclopramide as, oh, that's a crappy drug. We don't use that anymore. Metoclopramide's a prokinetic, but it actually works really well for nausea and anorexia for Palladia. So try ondansetron and meropenem first if you like, but metoclopramide is a good tool for some dogs. Not all dogs, some. And then prednisolone too. So prednisolone at 0.5 mg per kg can really improve the appetite and nausea. So I give it in the evening of Palladia if I have to. So Monday, Wednesday, Friday. But it's best to give on the non-Palladia days where possible. But if you have to on the Palladia days, it's in the evening. Or reduce the dose of Palladia if it's that bad. Sometimes when the nausea is horrendous and it's quite bad, you need to reduce the dose of Palladia. And then lethargy. You can have extreme lethargy from Palladia. It can impact the dog's quality of life. Take it seriously. Same with chemotherapy. And for Palladia, though, they mainly respond to an anti-inflammatory dose, so 0.1, 0.2, up to 0.5 mg per kilogram on the Palladia off days. Rarely do I have to give it on the same days as Palladia. I try not to because of gut side effects. And if it doesn't help, dose reduce or go every third day for Palladia. If it's severe, I've had one dog that was just so profoundly lethargic and had such a terrible quality of life that the owner was going to euthanize that we discontinued Palladia. It went away. So it's really, really important that if it's really that bad, any side effects on Palladia, you really have to stop. Now, weight loss. So people sometimes say, I need to take some Palladia, it's going to cause some weight loss. It is true. It can cause profound weight loss, but don't take it, please. It's just a joke. So if you get progressive unintentional weight loss, if you're on Palladia and you just notice, hang on a sec, it's now 20 kilos, 18, and you're just progressively losing weight, even if it's mild, temporarily stop. It's really important. Get the weight back on, feed it, do other things that you can many ways, and check the remission status sometimes. Sometimes they lose weight because they're actually out of remission, particularly for mast cell tumors. And then lower the dose or go every third day. And that's what I do long term. So I actually go straight to a dose reduction or every third day. Don't forget this. We all forget about monitoring the body weight. It's very important with Palladia. And then mild neutropenia. Unlike chemotherapy, which can cause profound drops in neutrophils, neutropenia and Palladia is usually transient and it's uncommon and mild. Same with cats. It's not really common. And if you just leave it, just watch it, it will usually go away within a month. I know it can be really scary, but don't change it unless the neutrophil count's less than 1.5, even 1. For me, I feel that I've had them drop really low and they all usually come back up. There's one case, one or two cases where I've actually dose reduced, but typically they go back up. And if there's sepsis, so less than 1.5, or they've got sepsis, then I think it's really important to treat those patients with antibiotics and aggressive IV fluids. I haven't had this. Some of the clinicians I've have had this. They're their patients. So know that if you actually get sepsis, you really need to take it seriously. And if they're lower than 1.5 and they're not sick and they're no fever, then you need to cover them with antibiotics and dose reduce in the future. So sepsis or any low count, you need to dose reduce by 25% or go to every 3rd day. And then for proteinuria and hypertension, this is important. It actually can be present in many cancer patients before treatment. So for some people, they say to me, oh, I didn't get a blood pressure, I didn't do urine. It's very important that you try to do it because roughly 37% of cancer patients, for no reason we don't know, have hypertension and 20% will have proteinuria. So please try to obtain it before starting Palladia where possible. And you want to do healthy age, and in a healthy age match control, it showed that healthy dogs can even have hypertension and proteinuria. This one said 0%, but we know that healthy patients can have this. And so it's just really important to do it at baseline. And for me, hypertension is particularly important because in people, it can be quite severe and can cause problems, as we know, with having hypertension. We don't really know the incidence in dogs. We know that 1 in 4 in people get it and 1 in 10 is severe, but who knows in dogs? I do think that it can be severe, but often because we monitor it, I think we don't tend to have an issue. And know that the hypertension isn't related to proteinuria sometimes. It can just be hypertension due to another reason. Why is that? Just for those nerds out there, it inhibits the VEGF signaling, so vascular endothelial growth factor, and increases endothelin 1. So for those studying exams, they know that increases it for hypertension. How do we manage it with hypertension? Amlodipine is great. ACE inhibitors don't work well. So remember, ACE inhibitors are okay for proteinuria, but not for blood pressure. Sometimes people say, oh, I'm going to give ACE inhibitor if I've got hypertension and proteinuria. You can try that, but then I tend to find you have to add amlodipine because it just doesn't do well for hypertension. And be careful of the white coat effect. So always do baseline because you can have those really nervous dogs that have blood pressures that go to 160, 180. Keep that in mind. Don't necessarily treat them and monitor them. Probably if it's more than 180, I would consider treating them. And then discontinue Palladia temporarily when you've got hypertension helps too. And when you reintroduce with the amlodipine, really monitor the blood pressure going forth. You just want to keep it stable. If it's really that bad and you reintroduce and you get significant hypertension, the amlodipine's not working, you need to dose reduce or go to every 3rd day. If you've got proteinuria, so a protein-losing nephropathy, this is uncommon. And I wanted to mention that sunitinib in people, the incidence is really low. And it may not be related to hypertension. But it's important because I won't go through the reasons why, but when you treat it is you can actually get nephrotic syndrome from having protein-losing proteinuria. Some people say to me, oh, I see proteinuria all the time, I'm just going to leave it. But nephrotic syndrome kills dogs. They get peripheral edema, hypoalbuminemia. It's really, really awful. And I've had one case, not my case, but a colleague of mine where it happened. And so for me, I do monitor it carefully. I think that it's important to do a urinalysis at baseline. And if there's any proteinuria, particularly if you've got a low USG, you need to do a UPUC. And anything more than 1, so I know the cutoff is half, but for treatment, but for Palladia, anything more than 1, I would actually treat. And ACE inhibitors or telmisartan is really good. So for a long time, we use ACE inhibitors, but everyone knows the pain of ACE inhibitors. 1 to 2 weeks later, you've got to check your urea creatinine electrolytes. And it's so intense to get owners to come back in 1 to 2 weeks later. And ACE inhibitors can cause you to go off your food. So imagine giving that with Palladia. What's causing the side effects? I found it really, really hard. And I'm really glad telmisartan came along because I'm starting to use telmisartan now. It is easy. You start telmisartan and then 2 to 4 weeks later you monitor. And you don't have to be so intense with the treatments. I mean, with the monitoring, you can usually bring them back into the Palladia schedule. So for me, I actually like telmisartan. But either's fine. You can use ACE inhibitors too. Just be careful of inappetence. And then hepatopathy. ALT and ALK-Phos are very uncommon, usually reversible if you pick it up early. And if any hepatopathy or these unexpected biochemical changes occur, you need to stop Palladia and pred. Because for me, giving prednisolone and lomustine or prednisolone and Palladia can actually exacerbate underlying liver issues. So really, really question whether the prednisolone is actually helpful for the case and stop it. And often you just do a temporary course of Denameron and it goes away. Sometimes it has to be continuous because you reintroduce Palladia and it starts to happen again. When do I not give it? I don't give it if there's certain underlying liver diseases where I'm just like, no, this is just going to make the liver disease go off the edge. If the ALT is more than 590, remember the hepatocellular study, I just feel nervous about going more than 590. And at the same time, so any severe liver disease, you really need to not give it, but also avoid drugs that can exacerbate hepatopathy. So lomustine or TMS, so sulfonamides and prednisolone. So really reduce that when you've got hepatopathy. Take out all the causes, and then you can manage this effectively. This is an important one in dogs. It's usually seen in the first month. So having shifting lameness or muscle pain, it can actually be quite profound. But usually it's mild and temperate and it goes away without anything. So dogs will have this, oh, listen there. You think they're lame on the left or right. You think it's arthritis. You keep checking it. Can't pinpoint what it is. It can be bone pain. It could be muscle pain. It's just this shifting lameness. And it can really impact the quality of life. So if that's the case, you need to give NSAIDs on the non-Palladia days. But if it's persistent, you need to dose reduce, discontinue, and sometimes permanently discontinue. I had one dog that was so profoundly lame on it, was screaming all the time. I had to stop Palladia. So yeah, sometimes it can be really bad. And then other things that can happen is what we call vitiligo or skin pigmentation or hyperkeratosis. So we see dogs that have this depigmentation around the nasal planum or around the eyes. So this is a very typical example where owners just get really stressed out and think they have the systemic lupoid disease, but it's actually just the Palladia. Palladia just affects the melanocytes, and it can also cause keratosis of the nasal planum and crusting of the feet. Often it's not clinically relevant, and I don't worry about it, but know that sometimes when you've got these skin changes, it can cause some itchiness. But I don't typically worry about it. I think it's not really significant. And then pancreatitis, very rare, and I won't go through it, but you temporarily discontinue and treat for pancreatitis. Renal toxicity, you can get nephrotic syndrome from the protein loss. It's not convincingly reported in dogs, but Ella, remember Ella, my metastatic osteosarcoma dog who was on Palladia for 5 years and died of renal failure? It did cross my mind that did this patient die of chronic renal failure because we're 15 or Palladia? And I just wanted to get you to think about that. I'm not saying Palladia caused it, but I really think it's important to know that Palladia can affect normal cells too. So for me, I always question, did Ella die of renal failure from Palladia? I still question it to this day, but know that it can potentially cause it. So just watch it. If it does occur, it's going to be rare, and I think when it does, I usually stop and I don't do it anymore. Now, what if they have underlying renal disease? So some people say to me, I've got mild renal disease. Can I use Palladia? You can if it's mild and the renal parameters are stable, not in an acute renal failure patient or patient that's not stable with renal disease. You just got to proceed with caution because in these cases, you want to make sure that they're well. You want to make sure that any chronic kidney disease patients, if they're sick, think about it, they're on Palladia, if they vomit or have diarrhea, they're going to end up in hospital and they can go into acute renal failure. So you need to tell owners that having renal disease complicates things because if they get dehydrated at all, they may end up in acute renal failure. So really just let them know that they can't try supportive care meds for too long. And if it's severe, I wouldn't do it because I feel like it might tip the dog over the edge. And avoid NSAIDs in those with renal toxicity or any drugs that may cause renal damage. And cardiotoxicity, almost done. I'm just going to go through the main things. So cardiotoxicity is uncommon in people. It's not convincingly reported in dogs. If it occurs, you just stop. I just think there's not any risk. Anemia can be mild and it's not clinically relevant unless it's due to a mast cell tumor or ulceration. So when you get anemia, don't go, oh, your cat said it's not an issue. I would check for an ulceration. So do a rectal or check for markers of ulceration. And then this was just the rare case of I looked it up and goes, whoa, that's weird. So this opportunistic infection, this dog, poor thing, was on Palladia and had this infection, pneumonia. And then death, gastric ulcers from diarrhea left untreated. It's a wrongful death. It feels like a wrongful death for owners. Cardiotoxicity, renal failure. These are cases I had that may have died from it. Ella was one of them with renal failure. But know that you can actually die from having Palladia. So it's not a benign drug. It is helpful, but it's not necessarily benign. And then I'm going to wrap up soon and finish with the quiz. It's a very big topic and I can't go through everything. So I left a lot of it for Q&A for those who I haven't had my answers addressed. But I wanted to ask you a question. What is the recommended dosage in dogs before I go into cats and finish up? So I'm going to release my poll. So bear with me while I figure this out. Polls or quizzes. There we go. And then I'm just going to go. I'm going to launch my poll question. So what do you think the recommended dosage is? I'll give you about 20 seconds or 30 seconds to answer this. Oh, people are listening. Great. Okay, I'm just going to end the poll here and release the answers. So hopefully you can see the results there. So most of you got the right answer, 2.4 to 2.9. This is also in cats. Some said 2 to 2.75. Sorry to trick you there. 2 is a bit low, so I wouldn't start at that recommended dosage. 3.25 is really high for those who entered a bit late. Know that, yes, you can give it at that every second day on Monday, Wednesday, Friday, but that's not what I recommend. You can actually do lower. And you want to use the lowest dose that can keep effective. And someone said all of the above. I get why you would have said that. You can actually use all of the above, but remember to start between 2.4 to 2.9. So with monitoring, before we finish up, I just wanted to say with monitoring, physical exam and body weight, really, really important. So remember weight loss is, I'll move this out of the way. Physical exam and body weight's really, really important, including a rectal exam for diarrhea. I actually do it routinely for patients that come in for a Palladia recheck, even though the owners don't say, and I'm surprised to find some of them will have diarrhea or melena. You do a CBC and chem mainly to check for hepatopathy, azotemia, or anemia to suggest ulceration. Urinalysis you do routinely, and then plus or minus UPUC, that's a urine protein creatinine ratio. If there's any proteinuria that changes, or you want to check if it's effective with therapy you're giving. Blood pressure is really important, and measure the cancer. That could be imaging or with calipers, photos, and stable disease is good if you're clinically well. How often do I do it? I do every fortnight for two visits, except the second visit's just a CBC. And then I do 4 weeks later, and then 6 weeks later, 8 weeks later, and then eventually 8 to 12 weeks. I do extend it to 12 weeks for the very, very stable patients where I can confirm they're doing really, really well. But remember, people forget that diarrhea is bad. So when you start to extend it, remind them diarrhea is bad. They get freaked out at the beginning, the owners and the vets, and then we all forget about diarrhea and weight loss. So just keep that in mind. Stop if it does not work or there's side effects. And some pets require a bit more in the first month. So sometimes you try and go, hey, Palladia, it's just not working. This patient's not doing well. Geez, it's such a pain. But if you persist, know that most patients can do well. So you need to just adjust the dose, do something, do more frequent visits, but you usually get it right. And then with cats are different. Unfortunately, they're really little. Some cats are 2 kilos, so you need to get them compounded. Bovo in Australia does do this from raw Palladia. You cannot split the tablets. It's not recommended to do that. They're not evenly distributed. I know people say, oh, but it works, but it's not actually recommended in that way. Cats actually have more side effects, 20 to 70%, and it's typically mild. And again, the same hospitalization and death rate. But for cats, it's anorexia is the main one, and weight loss, but anorexia. Cats do weird things. They just get anorexic from chemo too. So know that it's different in cats. And with cats, they actually can get more thrombocytopenia with the bone marrow suppression. So with dogs, I said they can have this transient neutropenia. Cats can get that too, but they can actually have drops in the platelets, which I don't care unless it goes below 75 or even 50. It usually comes back up. And know that cats uncommonly have liver damage, azotemia, shifting lameness, all that thing. So cats are usually very different. Cats don't really have actually shifting lameness and proteinuria and hypertension, but I still monitor for it. Just because it's not reported doesn't mean it can't occur. So know the monitoring is very similar in cats. Pancreatitis, which is rare in dogs, have not been reported in cats. And cats can get this generalized hyperpigmentation as well, and it just doesn't mean anything. So what do I do in cats? Drug holiday and supportive care is important. I do similar monitoring to dogs, and I think they should be monitored in a similar manner, except focus on the fact that they don't have as huge range or different side effects, and typically anorexia. What about safety? And we're wrapping up. So this is one of the last slides. So safety for Palladia, it's primarily excreted by the hepatobiliary route. So that means that predominantly feces, and you get them in mainly metabolites. So for me, I find that I just give it a clearance time of 1 day. No one really knows. Richard may know, but for me, because it's excreted as predominantly metabolites, I think the amount that's going to be in urine feces is really, really small. And so I'm not too worried about it. And if owners are, just tell them the first day. And some tips and tricks with Palladia is don't split the tablets. Not really a safety issue. I mean, it is anti-angiogenic, so you wouldn't want females or children kind of holding it with their bare hands, but you don't want to split it because it's not evenly distributed. And accurately check the dose with another person. I have these eyeballs here to say, look, check this drug, and I mean it. Get them the bottle and get them to look like this and say, open it up or show you. So just as a handy tip for those who don't know about Palladia, they actually come in different colors and they have TKI and the concentration on it. So I know this off by heart, but when I get shown Palladia in a bottle, I can tell, oh, that was the wrong one. That's 10, that's 15, that's 50. But really check the bottle and really physically check. It's like prednisolone. You can easily get 5 milligrams and 20 milligrams wrong. And we're so busy some days, but this is so important because if you give 50 milligrams in a little dog that's meant to get 10, you're going to kill it. And then dispense in a child-proof bottle, Ziploc. So when I prepare Palladia, it looks like this. I actually get gloves out. I get a bag, Ziploc chemotherapy bag, if not a Ziploc bag, some cytotoxic labels, and I label everything, even though it's not necessarily toxic. And I chuck it all into a paper bag with some spare gloves for the owner. And then I think it's important to wear gloves when handling it. It is anti-angiogenic, it's still anti-cancer, not cytotoxic. Less worried about it than chemotherapy, but it's important. And I think pregnant women and children should avoid it because if you think about it, they've got blood vessels growing, fetus blood vessels and growing blood vessels for growth. So you really want them to avoid it where possible and provide them a handout. It's important for owners to know all this. So summary. Palladia can be used for so many cancers: mast cell tumors, gastrointestinal stromas, metastatic, osteosarcomas, carcinomas, neuroendocrines, cats, mast cell tumors, oral squamous. So there's a lot of cancers you can treat them for. So know that it's very, very good for many cancers. I didn't mention, but splenic hemangiosarcomas aren't good. Soft tissue sarcomas tend not to be good. So they're the ones that when you have a soft tissue sarcoma or hemangiosarcoma, you don't really use Palladia. What are the pros and cons? The pros is it's oral, 3 times a week at home. Owners love that. Most side effects, if you pick up early, will go away. The cons, it can be really expensive in large dogs. Has potential to cause lots of side effects. You must be alert about it, even if mild, and don't skip a recheck. Lifelong medication. No one knows how long you treat it for. Like I said, if you can't see the tumor, how long do you treat it for? If it disappears, how long do you treat it for? This is a big conundrum, and it's really, really hard. Sometimes I go, oh, the owners don't have money. I'll stop after 6 months. It had metastatic mast cell tumor, but the owner didn't have money. And I aspirate the spleen and liver, and there's no mast cell tumors anymore. I stopped, and I regret it when it comes back. And I try Palladia again, going, it should work, but it doesn't. So sometimes know that it's really, really hard. When you start Palladia with a terminal illness, you kind of go for a long time. I do think about stopping after a year, but it's a really hard one. It's a really hard one because I've had them go either way. So that's the conundrum. And again, with Palladia, remember how it has a slow death and a quick death? Sometimes it can take 6 to 12 weeks before a response can occur. So it may not be a good option for rapidly dividing tumors. So with that, I want to thank you all. Sorry we started a bit late. It's a bit longer. I really appreciate you guys listening to my talk. We've had a lot of turnout tonight, 71 live, so that's great. And I wanted to let you know that we are, for those who can travel to Queensland, we are holding a workshop to teach you more oncology. I'm very passionate about educating. So we have Dr. Stuart Ryan, a surgical oncologist, Amy Land and myself teaching oncology lectures on day 1. And day 2, we're doing a chemotherapy workshop. And you can head to our website and find more details. But we're going to make it a relaxing retreat where you have yoga, group walks, really enjoy your time while learning about cancer. Because cancer sucks, quite frankly. I want to make it an enjoyable experience. So when you come, there's going to be prizes, live music, lots of alcohol, lots of freebies. For the chemo workshop, lots of chemo products. So if you are, we have 50% off on 6 tickets left for day 1. And then early bird finishes on the 1st of December. But I will extend it to the 1st of January for those who want to come. So that's actually supposed to say 1st of January. So know that, use the code early bird. And then my son created this. And so for those who've been on my other slides, he didn't update it, but he created this and he wants to be a social media manager for my Facebook. And I think he actually does a pretty good job. So he did this. It's just a bit colorful, but he said he's Benji and he's established in 2017. And this is our cat, Bobby, who's established in 2024. We have another cat, but he didn't put him on there. Shows how much he loves the other cat. And so again, he actually did this. So 50% off day 1. I thought it was brilliant for him. He actually knew the price and he put it in. So kids these days are quite bright, and he actually put down what it will be with the discount. And he even wrote book now and the address. So that's from Benji. And so to finish up, one more question for you, the last one, and then we're done. And then there's lots of Q&A for those who want to stay. And I know it's long, so you can head off. So the last Q&A is, I'm going to go back and release this poll. Okay, so the last question I have for you tonight is, a dog eats McDonald's and has diarrhea. How do you manage it? I love watching it live. You can actually see people clicking. It's pretty cool. Sorry for those who can't. So I'm actually going to end the poll when most people have answered. Okay, so I'm going to share the results. So I don't know if you can see the results, but I'm surprised no one said stop the macas. That's what I would choose. And then there's metronidazole and probiotics. Yes, stop prednisolone, temporarily stop Palladia, and resume Palladia when the diarrhea is resolved and there's been adequate gut rest. And all of the above. So most of you who said all of the above, that's correct. But whatever you pick, it would be correct. Surprised no one chose macas though. And that's it. So thank you so much, everyone. We're going to Q&A now, and I have some of the most popular questions up. But what I'll do is I think I'll just go through questions that you asked first, and then those who want to, I've got other Q&A that you've emailed over. So thanks everybody for listening. Okay, so I think I can let you guys unmute, and I think this is nice to do that. I'll just say unmute yourself. So for those who want to, you can actually unmute yourself for questions. If you're shy, that's okay. You can just ask in the Q&A box and I'll actually go through it. So I've written unmute yourself, and if you want to, you can start your videos. So if anyone wants to ask any questions and feels brave, you're welcome to. Otherwise, I will go through the Q&A that's on our questions, and I will also go through the Q&A in the chat box. But look, it's quite a long night, so for those who want to go, you can. Those who are keen on learning more at this time of the night, I will go through some extra stuff for as long as you need. So thanks, Richard, for attending. The rest is Q&A. You're welcome to stay for as long as you like as well.
Yeah, thanks, Kat. It's been, and thank you for the privilege of sponsoring tonight. It's been a great talk, and
thank you.
I've learnt lots of extra tips and tricks about Palladia myself. So
thank
you.
Great. Yeah, and some of the cancers are just recently been published too. So you'll have new data on cancers that can be used. Okay, so I might go through the chat. I've got here. Okay, so I've got someone from Fiji. Oh, they just want to know about support. Okay, for that, if you can email me personally, that'll be great. If you're asking if Zoetis is available, I was quite surprised that I had a lot of questions from Singapore and Philippines, and I don't know about Fiji, but if you look up if Zoetis is available in your country, they will have Palladia. So just find out. If you are having trouble when you're in Fiji and you want to source it, maybe, I don't know, Richard, who can they contact? Will they be able to contact you?
Yeah, first port of call would be their local Zoetis office, if there is a Zoetis office in their country. Surprisingly, drugs are not always available in every country. I can't guarantee that Palladia is directly available, but there may be some means of importing it. So you'd have to check sort of your local import rules around bringing pharmaceuticals in. But yeah, start with your Zoetis office if you can.
Yeah. And just so you know, for those, everyone has a different regulation in their country. So Australia uses an APVMA. It's like a strict regulator if we want to bring in medication.
Yeah.
Would Palladia be available in India to buy? Same thing. We have a lot of international attendees, so you just need to check with your local representative. And then the next thing would be then finding out from your regulators whether you can get it shipped. And if you can, there's no reason why you can't get it shipped from another country as long as you've got that approval.
And even human pharmacies can often access veterinary drugs. So you may be able to inquire at your local human pharmacy and see, what arrangements they can make.
And then I've got asked, can we please get a copy of the presentation? Yes. They're quite large. So for those who actually want personal copy of the presentation, like the actual slides, I'll give it as a PowerPoint slide, PDF file. If you can just email me personally, we'll send that to you. For everyone who's attended live tonight, there's actually quite a lot of you. We will be able to send you a CPD certificate. Just give us a week or two to do that. It just takes us a while to generate that because we do each and every one. And then the live presentation, when we get a chance to just shorten it and just make sure it's like just the part that's the presentation Q&A, we will email that so you can have access online by YouTube. Can we use it for lipomas? You can try. I don't think it'll do anything because we've tried it for soft tissue sarcomas and don't have really good results. So I personally think it wouldn't be a really good one for Palladia. I'd be interested to see if anyone has good results from it. I think lipomas are really just a surgical disease, and I think people have tried triamcinolone and other things and it's just not been successful. Can I check where you say, for example, 25% response rate and the 50%, does the 50% of the, okay. So someone's just asking about when I say 25% response rate, I'm saying partial remission or complete remission, and the additional 50%. So it's actually additional a stable disease. So they're cases that are actually don't grow. When you say clinical benefit, that means stable disease, partial remission, and complete remission. Confusing, I know. So response rates, objective, clinical benefit is all of them, all three, and stable disease is just by itself. So when I say that in my presentation, it literally is. So that's quite good when you look at anal sac tumors and thyroid carcinomas. For compounded Palladia in cats, do you have the original product compounded? Yes, they use raw. They don't actually, the good news is they don't actually reformulate it. They do it from compounding. So compounding is where they do it from raw material, and that's actually best. So Zoetis actually do that for Palladia. I don't like the liquid. I think that's scary. They do liquid cytotoxics. That makes me want to vomit thinking about it. Think about a cat with liquid cytotoxics everywhere. I just feel really nervous about it. But yes, they can compound from raw. Yeah.
That would be your compounding pharmacy.
Yeah. Oh, it would be
not
the main one in
Zoetis,
Australia. Oh no, that wouldn't be Zoetis. Sorry if I didn't clarify. This is compounding not for Zoetis. Zoetis does not compound their own medications. This would be, for example, for Bova in Australia. They do a really good job with compounding. Do you use Losec only on Palladia days or daily? Daily. So sorry if that wasn't clear. For mast cell tumors, I use it daily, twice a day. So Losec is twice a day. Esomeprazole is once a day, and it's been shown to be very good at reducing the acid secretion in dogs. Is there a plan to make Palladia in smaller size for cats? Richard? 5
not
milligrams,
that I'm
maybe?
aware of. No.
Okay, no. So it would have to be compounded for that question through Bova. And then how long do you do a Palladia holiday for? Until the side effect resolves? Or do you get concerned if you stop it, for example, 5 weeks and the cancer will occur? I don't wait 5 weeks. I think that's a bit long. I know sometimes you have to, if they're quite severe, if you get really severe hepatopathy, you can't really start the dog back on Palladia because it requires hepatobiliary clearance and the dog to feel well. But I think 5 weeks would make me really worried, and I'll probably consider something else in the interim. Often I find with Palladia holidays, if they've been on it a long time and they're actually doing well, they can take 1 to a couple of weeks off, depending on the cancer. But typically I would just do a week roughly. For diarrhea, if it's quite severe, you have to wait up to 2 weeks. Again, I just do it based on what the dog needs. So if the dog has diarrhea and I've resolved it really quickly, I just say to the owner, start Palladia again 3 to 5 days when you've got normal solid stools. And if they're not sure, they should call you and ask, because it's really important they just don't start back when it's a bit sloppy. Does Palladia work for TCC? So I did have a brief slide on that, bladder TCC. So Palladia for bladder TCC, oh, it's a hard one. They're heavily pretreated. So bladder TCCs were heavily pretreated in 67% of those cases that were treated with Palladia. I can't remember the numbers off by heart. I think it was 20 dogs. My colleagues in Missouri actually did this study, so I know quite a lot about it. And then with this, Palladia actually, it can help some patients, but it's really hard to say because a lot of them are pre-treated, and the average survival time is roughly 5 months. So I find that really hard because, as we know with some bladder TCCs, we know the average is roughly 2 to 3 months with no treatment, but some can just go a long time with anti-inflammatories. For me, that data showed maybe Palladia helps because it was around 5 months, but it was really hard because there was no comparison. There was no nothing compared to Palladia. So the answer is maybe. I'm not entirely convinced. If it was one of my last drugs to use, I've tried everything else, maybe I'll try it. I personally haven't used Palladia for TCCs much, so I don't know, but I would think that there is limited efficacy for bladder TCC. Do you have any interactions with nutraceuticals, and how about CBD oil? That's a hard one. Unlike Palladia, we don't think it has an antioxidant effect to work. So for example, doxorubicin requires oxidative pathways to work. And many chemotherapy drugs can interact with nutraceuticals. Don't know about CPD. For me, I guess if owners are really dedicated, I would just say, look, because of the potential unknown, we don't know if it's going to make the drug more efficacious or more toxic with side effects, or if it actually reduces side effects or makes the chemotherapy or Palladia less likely to work. So for me, I would avoid using nutraceuticals. CBD, it's a hard one because there's some data to show it can really help, dogs with pain. If I had to use CBD, I would say the owner similar thing. I just don't know. But what I would do is try Palladia first on its own. And then if it's tolerated, then add the CBD oil. Or if they've been on CBD oil for a while, I can. The thing with CBD oil is, as we know, for those who use it, you can get dogs that feel sick on it. So try not to give them all at once. Really space it out. And nutraceuticals like Denamerin are fine, if that's what you mean. But there's others you just don't know. So for me, I avoid doing it unless unless I absolutely have to or the owners wish to, but it's at their own accord. Then I have effective of cat on nasal squamous cell carcinomas. Don't know. We don't actually use it a lot for nasal squamous cell carcinomas. We know in dogs, Palladia doesn't work well for nasal squams. Nothing works well for nasal squams in dogs except surgery. Um, for Palladia, I have to admit, I have used it a few times and I haven't had good results. I don't know why. I've had really good results for oral, but not really for nasal. I think we just need more data. So I don't have much experience to let you know, except my minimal experience wasn't great. So sorry I couldn't answer that one completely directly. Um, and then I've got here, we've resected a grade 3 mast cell tumor from a 15-year-old 2 weeks ago, started Palladia for suture removal. Due to financial constraints, owners elected abdominal ultrasound for staging with no obvious mets. I wouldn't do Palladia in that case, no. So I feel like there's no strong data or any data to show that Palladia as a sole agent for high-grade mast cell tumors will do well. I mean, I'm sure it will do better than nothing, but Palladia is expensive, or it can be. The dog's alive a couple of years later, it's going to cost own an arm and a leg. So for me, I would use vinblastine or pred or vinblastine lomustine, which has the strongest data if there's no metastasis. I do think that doing nothing will make the dogs most likely to die of metastasis. But in the adjuvant setting, there's no conclusive evidence to show that will help. The big but is, and I didn't go through it in the presentation, is vinblastine and Palladia together has been shown to extend survival. So you could use that combination. But Palladia alone, no one knows. And I typically don't, based on knowing Palladia doesn't work well in the adjuvant setting. Any known use of maxillary osteosarcoma? Not much out there. I've tried it anyway, and I've tried chemo on any kind of osteosarcoma and soft tissues. They don't do great. Sadly, response rate less than 10%. I don't know if that's the same for Palladia, but I don't think they do great. It's mainly for pulmonary metastasis for osteosarcoma. So no one even really does Palladia and the Gross disease for appendicular. There's quite a lot of questions actually. We have a dog with and anyone who wants to go. Those who want to stay, I'll go through every question. We have a dog, Evan, who is mast cell tumor reoccurred after surgery on the shoulder, vinblastine given 4 doses, and he switched to Palladia. On Palladia doing poorly, hemoglobin low and weight loss, stop. Yeah, stop. Don't do it. It sounds like if the dog is doing bad on Palladia, first check remission status. Is a dog doing bad because it's actually doing badly because it's not working for the cancer? If you check remission status and it's actually responding, or if you can't in that situation, you said it reoccurred, but if you can't, I guess for me, I would stop. That sounds horrendous. The dog's doing really poorly and weight loss. I would not continue. If you do have to persist and you think it's actually working for the cancer, a huge dose reduction in every 3rd day with lots of supportive care. But for me, I wonder if it's bleeding from a gut ulcer. I think that sounds really horrendous and I wouldn't continue. It sounds like progressive disease or the drug. It sounds horrible. Yes, this webinar will be recorded, including the Q&A, and that will be sent when we have time in the next 1 to 2 weeks. Again, if you want a copy of the slides, just email me personally. Any specific considerations for Palladia in diabetic dogs? And diagnosed with diabetes approximately 3 weeks beforehand. We're avoiding pred, but antihistamines, etc., are being given. And then you're finding Palladia days have worse blood glucose control. I wonder if the dog is having worse blood glucose control because it's feeling sick. Maybe just check that. We use Palladia a lot with diabetic patients, and I'm sorry I haven't noticed that. I don't think I've actually documented the blood glucose closely enough. Maybe it does do something. Because remember the cases with insulinoma where you're just on Palladia and they actually can increase, but that's different because it's insulinoma. For me, diabetic dogs, I just want to control first. So for me, any concurrent morbidities, hypoadrenocortisone, kidneys, liver, whatever, it just needs to be controlled before starting Palladia or while on Palladia. Because for me, that dog who has diabetes mellitus cannot afford to get sick. If it's going to go off food from Palladia or if it's going to be sick, it's going to get dehydrated, that blood glucose will just go out of whack. And so anything you can do to minimize it like you have by reducing the pred will be helpful. So for me, diabetic dogs or concurrent morbidities, you really just have to have them controlled well. And it's important that owners know it's complicated. You've got diabetes. It's not going to be easy on Palladia because if your dog gets sick, blood glucose is going to go whack. And so in those cases, it's annoying. You've got to get them to call you. They've got to come in. And sometimes those cases are so painful that you just have to stop Palladia. If the dog or cat got a secondary infection but normal white cell count, would you take a Palladia holiday? No, I'd continue Palladia because I think it doesn't cause marked neutropenia. So I would continue. It's different to chemotherapy. So for me, I'd persist with Palladia if Palladia is tolerated. If you're worried about the secondary infection, then absolutely stop the Palladia. But if Palladia is tolerated, keep going. This is a question for Richard. Last one, Richard. Is there a chance of studies of Palladia in India? Oh, lots of dogs with mast cell tumor. Oh, so a lot of them are asking, about Palladia in India. I think you have to check locally, that person who asked that question.
Yeah,
Yeah, sorry about that.
I don't think Zoetis will be doing further studies ourselves, but so
Mm.
most of the literature that Kat's shown tonight is are studies done by non-Zoetis people, so universities and oncologists like Kat doing their own studies and publishing. So yeah, I guess there could be studies done out of India, but they won't be Zoetis studies. They'll be
Yeah.
independent studies. Yeah.
Maybe do one on renal carcinoma because we don't know
Yeah,
much about whether we just
yeah,
think it works well because it works in people. There's
yeah.
another question. You may have touched on this already. That's okay. I know it's so late. I'm so sorry, everybody. The literature and the use of pheochromocytoma. So I actually only touched based on it briefly. Has a very low, and it says the literature with the use has a very low case. Yes, 5. Are you using this for success and do you expect success? And are you getting tumor reduction and tumor stabilization? I've only ever used it in 2 dogs, and it's so hard because one did really well and the other didn't. The one that did do well had pulmonary metastasis, and I thought it was not going to do great because it actually had clinical symptoms from the pheo. But since starting the Palladia, its hypertension improved, it clinically improved, and the nodules in the lungs actually shrunk by half. So that was a win for me. But the other one did dismally. And I do agree, there's only 5 cases. Maybe they actually accumulated the 5 cases that did well. So I do think that there's lots of things you can do for pheochromocytomas, but I do think Palladia plays a role if it's inoperable because it's good for neuroendocrine tumors. So keep it as a drug in the back pocket and know that you're right. There's only 5 cases out there. So I would use it as a tell the owner trial and see. It's got metastatic disease. We can't operate and see how you go. And so I've only got 1 case that did well and 1 that did badly. So that's again not much for you. So sorry about that. If you had a cat with metastatic intestinal mast or tumor who had surgical resection but doing well on Palladia for approximately a year, then developed an agasaka, which was surgically removed, wow, would you treat the anal sac tumor with Palladia or be concerned Palladia isn't going to help as it developed on Palladia? Oh, that's a really, really good question. That's a hard one. Wow. So for me, I would be concerned absolutely that the Palladia wasn't going to help as much. Oh, it's your own cat, the vet says. Yay. Oh, that so sucks. Of course, the vets have really unusual cases. I really need to think about that one a bit more. Email me personally because I just need to think about that one a bit more because you are right. If it developed on Palladia, probably not. So what I would do in that case, I'd probably focus if the aggressive agasakas in cats we don't know a lot about. If the agasaka was small, not aggressive, I would just remove it and just keep going with Palladia. Does that sort of make sense? But if the agasaka was very aggressive histologic, I'm worried this may potentially kill the cat, not the intestinal mast tumor anymore. I doubt. I think the intestinal mast tumor would be more aggressive. I would then, if I was worried about the anal sac in any way, then I would switch to a different drug temporarily and then go back on Palladia. That's sort of my thought process on it. But basically, you're right. If you've been on Palladia and the cat developed that tumor on Palladia, probably not going to help as much. And for me, I think the intestinal mast tumor is horrible prognosis. So as long as the histo for the anal sac's good, just stick to treating the intestinal mast tumor, and hopefully it won't develop another anal sac tumor on Palladia. That would be weird. Yeah. So yeah, thanks everybody. And then I did have other questions. I just don't know if people want to hear about it still because it's quite late. There's still half of you on. Some of these questions are quite relevant, but I feel like it's late. I'm happy to stay. There's only 10 slides left. So I will just do it for those who want to stay and learn a lot about Palladia. I'm all for sharing knowledge and making you guys better out there for using it. We all should be using it. And I think it's really important to be informed on how to use it. So the questions we got asked is maintenance post chemotherapy in the adjuvant setting. No, the answer is no. There's 3 studies I'm going to show here where it's no. So with this study, Cheryl London, who actually did the Palladia study, she showed that Palladia with piroxicam and metronomic cyclophosphamide 2, given after you do appendicular osteosarcoma with amputation and carbo. So that's the standard of care, amputation and carboplatin for osteosarcoma. They did this as a maintenance. And look at the survival curve for those who are nerdy survival curve people. Same. Lines. Oh, sorry, I might have to mute that person if that's okay. Bear with me. I'll just go. Who is that one? Mute. Okay, I think I got them. Okay, so basically, you can see the survival curve here is on the same line. So Palladia was this one, and the other one was, yeah, so no difference. So based on that, no. the addition of Palladia to a metronomic cyclophosphamide protocol following amputation and carpal did not improve survival and remission duration, so I wouldn't. And same with this one. So metronomic combined as well with carboplatin, and then this one was a no as well. And then this one with another one. There's actually a few. I just put 3 in as an example. And this one is splenic hemangiosarcoma. So they use metronomic chemotherapy after giving doxorubicin, for example. So they use doxorubicin. Sorry, I'll say it again. So you got splenic hemangiosarcoma, you do splenectomy, and you do doxorubicin, and they added metronomic after. And again, some studies showed it was good and there was a survival difference. And then others showed that it wasn't for metronomic. But when they did it with Palladia, they showed Palladia had no difference. So if you add Palladia after, like as a maintenance after splenectomy for hemangiosarcoma and doxorubicin, it made no difference. But for metronomic, it's controversial. So for me, I didn't include a good example. So this one wasn't a good example. So apologies for that slide. If you get a copy later, I will actually edit this and give you the right paper for it. But know that when you do have studies that do, and there's quite a few out there, several, I think, at least 3, where you do maintenance metronomic or maintenance Palladia post standard of care, no improvement in survival time. So based on that, I would not do maintenance Palladia post adjuvant chemotherapy in the microscopic setting. So Palladia in the microscopic setting for solid tumors, there's no significant improvement in outcomes. Treatment in the microscopic metastatic disease using Palladia alone or in combination does not improve survival. And there's no increase in the rate of disease progression as well. So based on this, I typically don't use in the microscopic setting. And then the other question we got asked, this was a common one, can you use NSAIDs and which one? You can use any of them. I really like piroxicam because there's a lot of data for it. But as you know, piroxicam can cause a little bit of horrendous side effects. So piroxicam I love, but there's occasional cases where I'm like, I wish I never used it. I had a dog die of gut ulceration. And so other ones, Previcox, Deramax, and Meloxicam, they're all quite good. I use more COX-2 inhibition, and mainly because COX-2 inhibitors or some cancers have COX-2 increase, and so by using COX-2 more specific inhibitors, you may have more efficacy. Sometimes it's not even that mechanism, but they tend to work a bit better for cancer. If you do use it, they have an increased risk of side effects, mainly from the NSAIDs, particularly in cats. So cats on Palladia with PRED and with particularly non-steroidal anti-inflammatories, they get kidney issues and they can actually have really bad gut issues too. But cats has more kidney issues with NSAIDs on Palladia. Dogs, it's more gut issues. So keep in mind that NSAIDs need to be given carefully. And I do think it increases the risk significantly. So really give it on the non-Palladia days if possible. Some cancers, so non-mast cell tumor cancers, there's actually been shown, and you'll see a slide where I've mentioned it, I just didn't go through it due to time. We can actually give non-steroidal anti-inflammatories daily. And by giving it daily, they show that it slightly increased the risk of side effects for non-mast cell tumors. And so in some cases, you'll just have to do it daily. But I don't like it. I think it causes a lot of nasty gastrointestinal side effects. So if you do it, it has to be for good reasons, as in the arthritis is that bad, it's going to cause euthanasia. Or it actually works for the cancer. So for example, TCC. And so for me, just try to avoid it if possible. And we have a lot of concerns with Palladia concurrently. Can Palladia be used with other drugs? Yes. Many other anti-cancers, so metronomic, chlorambucil, some conventional, so like vinblastine. Know that when you use it with conventional chemotherapy, because there's studies with it with vinblastine and doxorubicin, you have to reduce the actual chemotherapy drug. I don't think there's a lot of data to show Palladia and chemo will be better than Palladia alone. So for me, I find you have to dose reduce so much the chemo drug that I worry that sometimes I'm start at 1.6 and I go to 1. Am I actually giving anything efficacious for the chemo? So for me, I just stick to one kind of sole drug. That's a personal preference. Radiation therapy, yes, but you increase the risk of side effects, particularly with mast cell tumors. So you have to time it. I won't go through that in depth, but yes. And then non-cancer drugs, again, NSAIDs and prednisolone give on the non-Palladia days where possible. And this is the paper. This is the paragraph, sorry. This is the one to show that you can actually do it a low dose. That I didn't write that one. That was a Chon. It was someone else. And in that paper, they showed you can give it safely, typically every second day. Cytopoint, absolutely. Apoquel, careful. Apoquel works differently. And yes, you can give it with Palladia. No studies out there. It's more just an anecdote. Just be careful watching the side effects because Apoquel causes GI side effects and same with Palladia. So try to just do one at a time and then just space it out a bit. Again, this is just to show you the dark dosages you would have to reduce vinblastine and doxorubicin. The use of lomustine, which causes chronic hepatopathy with Palladia, just makes me want to vomit. So I would never do that low dose daily. And then again, the answer is yes, you can, but chemotherapy needs to be reduced. Yes, you can with metronomic, and it actually has been shown to increase immunotherapy with it, like the immunomodulator effects. And then so maybe we should be doing it. So I actually do a lot of gold standards Palladia for, say, thyroid carcinomas, metastatic disease, but actually say if owners are really dedicated, add in some cyclophosphamide. Very well tolerated. Again, you can space it out, give cyclophosphamide later, but it does help with immunomodulation. And then these were common questions asked. So cats you can use with metronomic as well, but you get increased risk of azotemia. Remember how I said cats are weird? Cats with NSAIDs just get azotemia. So be really careful. And then I do think Palladia and metronomic work together, probably not for minimal residual disease. Remember how the studies I showed you earlier, where afterwards metronomic or Palladia doesn't really have a survival benefit. No markers to determine this. This is just based on, I think it may do better. Not great for soft tissue sarcomas, not great for hemangiosarcomas. It's been proven in the adjuvant setting as well. Response rate's probably less than 10% or so. Potluck. This case had intranasal sarcoma and it worked. So the potluck if you do it. Not with Stelfonta. That just, for many reasons, no. I won't go through that. But not with Stelfonta.